This conference will now be recorded.
Am I audible and clear? Okay, we all know the introduction part. Previously, it derived from the Italian word meaning malaria. Mal means bad, that is bad air. And now also the name is getting continued. Malaria continues to be the most important cause of fever and morbidity in the tropical world. Malaria has been eradicated from countries like Europe, most of the North America, USA, South America, Korea and Japan. It is still rampant in our India. You all know it is a vector-borne disease. Once again, I'm asking, am I clear? Shall I continue? Am I clear? I'm not asking any question, just whether I'm clear or not.
Yes, ma'am.
Yeah, okay, thank you. So, malaria is a vector-borne disease that you all know, and it is an infectious disease caused by protozoan parasites. It is widespread in tropical and subtropical regions, including parts of America, Asia, and Africa. You all are well versed. The transmission is via female Anopheles mosquito. There are like 6 species in female Anopheles mosquito. In those two, like Kulsisi and Stephensi are in rural and urban areas respectively, those particular species. Malaria is an acute and chronic illness. It can present like acutely, or it can prolong, or it can be even present as like a chronic illness. It is usually characterized by paroxysms of fever, chills, sweats, fatigue, anemia, and splenomegaly. This is the clinical spectrum of malaria, and in a definition part, it could be like both an acute and chronic illness characterized by all this symptomatology. It has played a major role in human history, having caused more harm to people than any other infectious disease. Malaria is of overwhelming importance in the developing world today, with an estimated 300 to 500 million cases and more than 1 million deaths each year. You all know malaria kills in 1 year what AIDS kills in 15 years. It is not an exaggeration, like see, malaria is very rampant and very prevalent. Like acquired immunodeficiency syndrome, it is also dreaded entity without any drugs or treatment or any vaccines. But you know that is a chronic debilitating disease. But malaria, even it is due to a small vector-borne disease, like attack rate is very high. Even deaths are also more. So what are the parasites causing malaria? You all know the 4 species, and the 5th one is Knowlesi. We all know the 4 species, that is Falciparum, Vivax, Malaria, and Ovale. I don't think you require much more information regarding this because you are very well versed because you completed your microbiology part. And you know the most dangerous out of all these 4 species is Plasmodium falciparum malaria. Why? You can ask why Plasmodium falciparum is more dangerous. Because it has a property of sequestering and adhering to the blood vessels, leading to acute Am I audible? So sequestration and adherence to blood vessels and everything, like it leads to all the dreaded complications like acute renal failure, pulmonary edema, cerebral malaria leading to coma and encephalopathy. Because the particular entity is having the property of sequestration, like entering or adhering to the blood vessel walls with the specific receptors, resulting in more dreaded complications. That is more particular with Plasmodium falciparum. So out of all these 4 species, the dangerous one is Plasmodium falciparum. So one new species that was discovered in 2004 is Plasmodium knowlesi species. Causes malaria in macaques but can also infect humans. Falciparum most dangerous. Falciparum accounts for 90% of deaths due to malaria, and Vivax is the most widely spread species because it exists in both temperate and tropical climates. So out of these species, which one is more dangerous? Your answer should be falciparum. Which one is more common? Your answer should be vivax, because it exists in both temperate as well as in tropical climates. The malaria life cycle is a complex system. You all are well versed with both sexual and asexual aspects. You all know sexual cycle occurs in mosquito and asexual cycle occurs in humans. What are the routes of transmission? Once already we discussed. One is vector transmission, bite by infective female Anopheles mosquito. Another one could be like direct transmission. Excuse me. Sorry. Blood transfusion. The parasite can live for 14 days in blood bottles under -4 degrees centigrade. The use of contaminated needles, and one one entity that you should know is congenital transmission. Even malaria is having the congenital transmission. So congenital malaria we can expect even in newborns. So there is a mother to newborn transmission via the placenta. So that is called as congenital malaria. So life cycle. What happens? First, when female Anopheles mosquito infected with malaria parasite bites a human and transmits the infective form of the parasite into the human's blood. So whenever an Anopheles mosquito bites the human, what happens? The infective form, what it is, sporozoites, enters into the human body. The second step, sporozoites, after entering into the cells, after entering into the body, it directly goes into the liver. So what happens in the liver? It multiplies and resulting in merozoites that burst out of the liver cells. So merozoites, after releasing that, those merozoites, they enter into the red blood cells, that is called as erythrocytic. Till now that is called as exoerythrocytic cycle. Erythrocytic because once it is entering into the red blood cells, forming new merozoites or developing into gametocytes, that is a reproductive form. Here sporozoites are entering into the human blood, releasing merozoites out of the liver cells, that is called as hepatic phase or exoerythrocytic phase. Once those merozoites released, those are affecting red blood cells. Here the merozoites affecting red blood cells, the product is also merozoite. Here this merozoite release could relate or in parallel with your symptomatology, because when these merozoites are released from the red blood cells, then only you get those symptomatology like chills and rigors. That is, in that way we specifically tell the periodicity of the malarial fever. The merozoite release will be different for the different species. That way we get the fevers called as tertium, quaternium and quartan type of fevers. So these merozoites enter red blood cells and multiply, forming either new merozoites or developing into gametocytes. These are all the reproductive forms, because these are the forms which enters into the mosquito. So when female Anopheles mosquito bites a human infected with Plasmodium, taking up gametocytes with its blood meal. So finally, from the mosquito to the human to the mosquito, this is the thing. Sporozoites, infective form, which develop from gametocytes, travel to the salivary glands of the mosquito. So once merozoites releasing out, that is causing clinical symptomatology. At that phase, gametocytes will be formed, that is the reproductive form. So those gametocytes will be taken up by the mosquito, and in the mosquito it is again converted into sporozoites, and when that mosquito bites a human, again the life cycle will continue. I don't think you require much explanation on the life cycle of Plasmodium, because I think you all are well versed with this topic. So you all know, because sexual cycle is occurring in a mosquito, we call it as definitive host. Man, we call it as an intermediate host. Sporozoites are infective forms present in the salivary gland of female Anopheles mosquito. After bite of infected mosquito, sporozoites are introduced into blood circulation. Same, we already discussed pre-erythrocytic cycle. And undergo developmental phase in the liver cell. Sporozoites are elongated and spindle shaped, become round shaped inside the liver parenchyma. So what is the structural transformation of sporozoites occurring in the liver from spindle to round cells? So multiple nuclear divisions develop to schizones. So after that, multiple nuclear divisions will be occurring in the particular cell, resulting in schizones. So each schizone contains 20,000 to 50,000 merozoites. Exoerythrocytic, what is happening in the tissue phase? Plasmodium malaria or Plasmodium falciparum sporozoites do not form hypnozoites. Develop directly into pre-erythrocytic shy-joints in the liver. Pre-erythrocytic shy-joint takes 6 to 16 days post-infection. Shy-joint structure releasing merozoites which invades red blood cells in the liver. This all we discussed. One entity you must remember is hypnozoites are formed by only malaria and falciparum. So recurrences will be there with these species, not with the other species, because they are not having other hibernating forms. So next, affinity of parasite to erythrocytes. What is happening? Because you all know all these merozoites are entering into next phase is exoerythrocytic phase. So what happens? Plasmodium vivax, Plasmodium malaria, Plasmodium ovale usually infects only young or older erythrocytes maximal. Parasitemia is 2%. Plasmodium falciparum infects all age groups. Like irrespective of what is the age of that particular RBC, it affects all this, like young RBC, newly produced RBC, old RBC, and everything. And then one more important thing already I told you, like it also adhered to the endothelial lining of the blood vessel, causing the obstruction, thrombosis, and local ischemias. Maximum parasitemia is up to 60%. So what is happening in erythrocyte? The same thing we already discussed. Liberated merozoites penetrate the RBC. 3 stages occur. You must know these 3 stages: trophozoites, shy-joint, and merozoites. So here from merozoites, again we are getting the end product is merozoite. Or I already discussed the reproductive forms called as gametocytes. So these are all the forms: trophozoite, shy-joint, merozoite, and ring-shaped forms. In trophozoite, hemoglobin degradation blocked by CP inhibitors and also hemoglobinases. Erythrocytic cycle, ruptured red cells release merozoites which attack new red blood cells. Continuous schizophony, repeated cycles will continue. So the happening of this erythrocytic cycle will go on continuing. In Plasmodium falciparum, infected erythrocytes with shy-joints aggregate in the capillaries of brain and other internal organs. That is why this is most dreaded complication occurred due to Plasmodium falciparum malaria. That's why we are insisting Plasmodium falciparum malaria is one of the most dangerous species. Only ring, we can see only ring forms in the blood smears. So shy-joints, we already discussed that tissue shy-joint on Plasmodium falciparum, malaria and knowledge ruptured once and does not persist in the liver. While in a case of Plasmodium ovale and vivax tissue, shy-joints are of 2 types. Primary type rupture in 6 to 9 days and secondary type remains dormant in the liver cells for weeks, months, or as long as 5 years and causing relapses of infection. For that only, because for these 2 drugs, we give another add-on drug that is called as pyrimethamine plus sulfadoxine plus pyrimethamine to prevent those relapses. This is life cycle of malaria parasite in mosquito. You need not remember entire thing. You have to know that once the reproductive forms or gametocytes are entering into the mosquito, they forms sporozoites. That what happens ultimately, the formed sporozoites are migrated to the salivary gland of the mosquito. This mosquito then goes on to infect another human host. So from here, like a clinical presentation is going to come. Like till now we discussed only life cycle, what are the species or what are the forms, like sexual cycle, asexual cycle, merozoites and all the things. But you have to know what are the clinical features. What are the clinical features, that is more important. Coming to symptomatology of malaria, we all know like typical classical features. Whenever those merozoites are released from the RBC, you get the clinical picture of fever with chills and rigors that vary with duration according to different species. Another remaining symptomatologies like enlargement of spleen, splenomegaly, nausea and vomiting, dry cough, pain and fatigue. Central nervous system, you get headache because we already discussed Plasmodium falciparum when it affects. It specifically had predilection to blood vessels and directly involving those vessels causing infarctions and also obstruction of the blood flow and all the other things. And also we get it usually headache in general routine fever presentations. Coming to the incubation period and prodromal symptoms. Incubation period for Plasmodium falciparum is 9 to 14 days, bivax 12 to 17 days, oval 16 to 18 days, and malaria 18 to 40 days. The incubation period can be prolonged in patients with partial immunity or incomplete chemoprophylaxis and as long as 6 to 12 months for Plasmodium vivax. So what do you mean by exactly this is like incubation period, entering of parasite into the body and appearance of the clinical symptomatology. This can vary from species to species and it almost like as long as 6 to 12 months for Plasmodium vivax. So for in some conditions, in some times, not in some conditions, sometimes even in incubation period, the child may have symptomatology like fever, nausea and vomiting, like mild symptoms one can expect, but usually incubation period is like free of symptoms, only entrance of parasite and before getting the patient having all these symptoms. So one, you have to remember in what are the other conditions where it is prolonged. One is partial immunity or incomplete chemoprophylaxis. Prodromal symptoms. What are the prodromal symptoms? We already discussed like headache, fatigue, anorexia, myalgia, slight fevers, pains in the chest, abdomen or joints. Because this we expect any types of pathogens that are causing fever. How malaria present clinically? Stage 1. Chills for 15 minutes to 1 hour. Caused due to rupture from the host red blood cells, escape into the blood. Presents with nausea, vomiting and headache. Stage 2. Fever may reach up to 40 degrees centigrade. May last for several hours. Starts invading your red blood cells. So in second stage, the fever will be very high and it also starts invading the other new red blood cells. Stage 3. Patient starts sweating, concludes the episode. Cycles are frequently asynchronous. Paroxysms occur every 48 to 72 hours. In Plasmodium, malaria pyrexia may last for 8 hours or more and temperature may exceed even 41 degrees centigrade. This is tertian malaria, 48 hours for vivax and oval. Quartan malaria for 3 days, that is for Plasmodium malaria. Tropical malaria, 48 hours, irregularly high fever, that is Plasmodium falciparum. Here the peaks are like a single peak. Here the peaks are irregular. You cannot expect only particularly a dip will be there and irregular high pattern of fever you can expect in the same day. We already discussed 3 transmissions. One is indirect transmission, one is direct transmission, and one more is congenital transmission, that law or placental or vertical transmission, that is called as congenital malaria. It is an important cause. It even causes abortions, miscarriages, stillbirths, premature births, intrauterine growth restriction, and neonatal deaths. Congenital malaria usually occurs in a non-immune mother with Plasmodium vivax or Plasmodium ovale. Congenital malaria, the first sign or symptom most commonly occurs between 10 to 30 days of age. Signs and symptoms include same fever, restlessness, drowsiness, pallor, jaundice, poor feeding, vomiting, diarrhea, cyanosis, and hepatosplenomegaly. Malaria is often severe during pregnancy and may have an adverse effect on the fetus or neonate owing to maternal illness or placental infection, even in the absence of transmission from mother to child. These are the severe manifestations of malaria. One is cerebral malaria. In that clinical presentation, it may begin slowly or sometimes abrupt onset also you can expect. Usually the child will be in a comatose state or sometimes the child will be irritable. GCS will be poor. And it also resembles many other encephalopathy states like tuberculous meningitis or acute bacterial meningitis or viral meningitis, sometimes post-epileptic or post-seizure drowsiness. sometimes hyperpyrexia or heat stroke. In all these conditions you expect, because in every condition where you are expecting any high temperatures, there the clinical presentations of delirium, drowsiness or encephalopathy one can expect. So those are all the differential diagnosis for this cerebral malaria presentation. And severe anemia. This is inevitable consequence of severe infection because intravascular hemolysis is going on. Sometimes because of this parasite, even normal red blood cells also getting lysed. And these RBCs are usually destructed in the spleen. So we expect automatically amount of blood is lost, resulting in severe anemia. And also other, like, only not only due to like intravascular hemolysis, there are other things also, because the survival rate of RBC is also getting lowered because of all these infections, resulting in sometimes structural abnormalities, deformability, easy lysis can happen, resulting in severe anemia. What happens if blood is very much lost? When the child is severely anemic, it may be fatal unless a blood transfusion is given, because oxygen carrying capacity of the blood will be gradually decreased. In severe anemia, what are all the conditions? The cardiac output will be increased. The child may land up into congestive cardiac failure, or the child may land up into tissue hypoxia, acidosis, and even impending respiratory failure followed by cardiac arrest and death. So these are all the severe complications or severe manifestations of malaria. One is cerebral malaria, another one is severe anemia, another one is renal failure. So even you can expect severe renal failure because of severe acidosis, and also intravascular hemolysis or hemoglobin obstructing tubules resulting in acute tubular necrosis. All these are the things you can expect. Other manifestations are hypoglycemias, hepatic dysfunction. Hepatic dysfunction, you can see jaundice. What happens in malaria? There is evidence of hepatic dysfunction. What is happening exactly is like with reduced clotting factor synthesis, reduced metabolic clearance of even anti-malarial drugs, and even failure of gluconeogenesis. What is happening when the glucose is not produced from the gluconeogenesis, then automatically the child will land up into hypoglycemia. That is the next subsequent complication that you expect is hypoglycemia. This is your question. What are severe malarial complications? And also even hyperlactate can also, severe lactic acidosis can also cause liver dysfunction. So you expect hepatic dysfunction like abnormality in coagulation profile and also jaundice. You can expect jaundice. You may ask, what is the type of jaundice that is most commonly occurring? It is hemolytic jaundice, that is it. Like indirect component will be more. Sometimes even you expect hemolytic, hepatic and cholestatic components. That is in part of your hepatic dysfunction, hypoglycemia. Next is shock. Cerebral perfusion will be decreased, tissue perfusion will be decreased, anaerobic like metabolism will be increased. Because of all those conditions, you get a component called as shock. Pulmonary edema, because capillary permeability and pulmonary capillary wedge pressures are also increased, leading into pulmonary edema. Automatically, with all these complications, expect fluid and electrolyte imbalances, vomiting and diarrhea. And important thing is secondary bacterial infection. In malaria, you expect secondary bacterial infection, that is more common. That's why when we are treating malaria, we usually add an antibiotic to prevent this secondary bacterial infection. Bleeding and clotting disturbances because of your hepatic dysfunction. Hemoglobinuria and black water fever due to your intravascular hemolysis. Am I clear? Am I clear? You people don't want to respond?
Yes, ma'am.
Yes, ma'am.
Yeah, continue. Cerebral malaria already discussed. Malignant malaria can affect the brain and the rest of the central nervous system, characterized by changes in the level of consciousness, convulsions, and paralysis. You can expect anything. So presence with hyperpyrexia even can lead to coma. Expect other complications. Usually on your cut section, brain appears congested. This is not our entity, pathologist entity. Complications. if you are completed with your nephrotic syndrome, one of the cause of secondary nephrotic syndrome, one of the triggering factor for secondary nephrotic syndrome is malaria. It can produce nephrotic syndrome, but in rare instances affects children mainly of age groups around 8 to 10 years. One important point is this: if nephrotic syndrome is due to Plasmodium malaria, then that nephrotic type is usually steroid resistant, that will not respond to steroids very much easily. Black water fever, we already discussed, it is infection with Plasmodium falciparum occurring in persons who have been previously infected and have had been inadequate dose of quinine, characterized by intravascular hemolysis, fever, and hemoglobinuria. All these things, what is happening? Finally leading to the cardiovascular collapse and shock. These are all the points we already discussed. Abnormalities in blood coagulation, thrombocytopenia you expect, resulting in bleeding manifestations. So how to diagnose malaria? With all the clinical features, we'll get some, apparently like almost 60 to 70% we diagnose with our history only. We'll get like history with all these things, you will think it could be malaria. And also when you're asking, you have to ask these three importantly. You'll ask general history, and also you need to ask any medications, and also recent travel history to endemic area. When there is a recent travel history to endemic area, then it's highly susceptible. And also area where the malaria is prevalent, automatically we can expect, right? So diagnosis, you'll ask your history. Then what you'll do? You'll examine the patient, right? So head to general physical examination, you will go with your head to toe examination. Generally, you see how is the look of the child, what is the consciousness level in the child, whether the child is drowsy, alert, or any lethargic. Because in cerebral malaria, if the child is having, sometimes I already discussed, we're present with coma or with drowsiness or with irritability. So general condition of the patient. So when next is you look for your pallor, right? You expect pallor because anemia will be there in this condition. Jaundice, we already discussed why hepatic dysfunction occurs. So you'll see jaundice, and you appreciate splenomegaly, right? Why splenomegaly? Because rapid cellular multiplication and structural changes will happen, and there also be, and those are all infected red blood cells, right? Ultimately, they should be removed. Those are removed only at the liver. So automatically the liver will be enlarged and cells will be getting enlarged. So splenomegaly you can appreciate. And also one important thing, one terminology you should know, that is called as splitting. The spleen is like capable of removing damaged intraerythrocytic parasites and returning the once infected red cells into the circulation. But the damaged erythrocytes are like ingested by spleen and the red blood cells are back into the circulation. But one disadvantage is that those RBCs will have shorter half-life. So in the in the general physical examination, after seeing your pallor, jaundice, fever and all these things, you have to examine whether the spleen is there or not. Usually appreciate splenomegaly. And also when you are doing your physical examination, one must rule out all the other possible causes of fever. Other signs of viral and bacterial infections you have to rule out. Examine rest of the systems to rule out any other potential infections causing fever. This is routine for any disease. Next, your microscopy, right? Two blood films we all know, thick and thin. Thick to know the parasitemia, thin blood film to identify the species. I don't think you require much information on this because you all know. Next is your like nowadays we are doing, what are we doing? Rapid antigen detection tests. Those are called as CAR tests we are doing. So we are checking antigen tests in our blood. It is not on antibody based. Those are antigen tests. The advantage is we'll get results within rapidly, like 15 to 20 minutes, not even 15 minutes, 2 to 15 minutes. That is the advantage of this rapid diagnostic test. We can use these rapid diagnostic tests alternative to microscopy in situations where reliable microscopic diagnosis is not available. Nowadays in our clinical settings, we are using these rapid diagnostic tests. Other methods like PCR based techniques detecting DNA and RNA. Now, because you people are very well versed, because nowadays we are doing COVID tests, right? All these are having, but antibody based, antigen based, PCR based, those are detecting DNA and RNA. Here also the same thing we are implying. Fluorescent techniques, relatively low sensitivity and specificity, cannot identify parasite species. Serological tests based on immunofluorescent detection of antibodies against Plasmodium species, useful for epidemiological, not for diagnostic purposes. These are all the differential diagnosis. Just need not know everything, but you have to know, because you should know the clinical spectrum. Then only you can apparently put your differential diagnosis. So how can you have your differential diagnosis? The clinical presentation of all these will be like some correlation will be there. For see, suppose in hepatitis the child may have fever, pallor and jaundice, so it could be one of the possibility. That's why you have to club everything with your general physical examination, with your proper history, with your travel history, with your occupation, where the child is residing. All these things come, because even in hepatitis you expect fecal-oral transmission the child will be having, but in hepatitis there will be some specific features, so these could be in favor of hepatitis. So these are all the things which may mimic malaria. So these are all the close differentials. One is hepatitis, leptospirosis, brucellosis, relapsing fever, typhoid fever, all these things. You need not memorize everything, just 4 or 5. Last entity within 10 to 20, 10 minutes, so we'll wind off the class. Coming to the management part of malaria. So till now we discussed definition, life cycle, clinical features, and what are the severe manifestations like cerebral malaria, renal failure, algid malaria, shock, intravascular hemolysis, black water fever, and all those complications or that end of malaria. And also how to diagnose, whether it is antigen based or your microscopy or DNA based or PCR techniques or fluorescent techniques. All these things till now we discussed. And also some differential diagnosis, how to differentiate malaria from the other diseases, followed by management. Now, after putting a diagnosis, this is malaria, you need to treat, right? So, management of malaria is based on the clinical presentation. In severe malaria, anti-malarial therapy must be given intravenously or intramuscularly. Oral treatment should be substituted as early as possible. It is very important to start orally. But in severe malaria, what is happening in severe malaria? Automatically, the child will be like in altered mental status. So obviously, the child will be unable to take. At that point of time, we start our drugs with either giving either IV or IE. Then whenever the child is regained his or her consciousness, you have to shift from those parenteral preparations to your oral preparations. Okay, doses must be calculated on a milligram per kg of body weight. It is important to weigh the patient and administer the dose appropriate for weight. So what are the drugs of choice? You all know, first oral drug of choice is chloroquine phosphate. The dose is 10 mg per kg, that is base, followed by 5 mg at 6 hours later, followed by another 5 mg at 24 hours and 48 hours. This is one regimen. Another one is like 10 mg, followed by 10 mg, followed by 5 mg. The total dose should go to the baby is 25 mg. Here also the same, right? 10, 5, 5 by 5. 3, 15 plus like 10. The same 25. The total dose should be 25 mg per kg per base. Why we are insisting on this base? For suppose you are at home now, one may ask, what is the dosage of this tablet, how to prescribe to this child? For suppose if the chloroquine tablets are available in 250 mg tablets, but in that entire 250 mg of chloroquine tablet, you doesn't have 250 mg drug. In that 155 mg base will be there. That is the drug you have to calculate. So for suppose the child is 15 kilos, 15 into 10, the dose should be 150 mg, around 155 mg. So the tablet you have to give the complete 250 mg, because the base of the drug in the 250 mg is only 155 mg. That's why we are insisting it is base drug. in the drug, because you people are at home, you are having a chance of prescribing any drug, just look into it what is the base in that drug, then only have to, or else you'll give the lower amount of drug because you'll cut it off or you'll do something. So one have to check the base. So the maximum base should be 600 mg on 600 mg, should not exceed 600 mg. Parenteral drug of choice, quinidine or a quinine hydrochloride, but nowadays we are giving artemisinin derivatives combination because hypoglycemias, prolongation of QTs, cardiac arrest will be more common with this drug. If at all, if you want to give the quinine sulfate, the dose is 30 mg per kg in 24 hours, divided in 3 doses for 3 to 7 days, plus tetracycline 20 mg per kg 24 hours in 4 doses for 7 days, followed by or plus pyrimethamine sulfadoxine or mefloquine hydrochloride. Nowadays we are not using all these drugs. If it is chloroquine sensitive, we are going with chloroquine sensitive. The important one is chloroquine phosphate. If it is having hypnozoid forms like Plasmodium vivax and Plasmodium ovale, we'll give pyridoxine and pyrimethamine and sulfadoxamine for 14 days in Plasmodium vivax and 1 single dose in Plasmodium falciparum. Plasmodium vivax and Plasmodium ovale only we give primaquine phosphate. The dose is 0.3 mg per kg base in 24 hours for 14 days. Maximum should be 15 mg. It should not exceed 15 mg. Artemisinin derivatives, it clears parasitemia more rapidly than quinine. It is more advantageous and it is comparatively safest drug. They are active against a broader life cycle range of blood stage parasites than quinine, and they are active against gametocytes even. Artemisinin derivatives include artesunate, artemether, artether. Artesunate is the preferred artemisinin. Clinical experience with artemether is limited and they should not be used for treatment of severe disease. Artesunate, we are giving nowadays artesunate. The standard dose of drug constitutes 5 doses. We give IV. First is 2.4 mg per kg as first dose, followed by 2.4 mg per kg at 12 and 24 hours, followed by once daily dose. This is not like we have to give 5 doses IV only. Once the child is able to take orally, we can shift the IV medication to the oral combination therapy. The oral combination therapy we use is the artemether plus lumefantrine pediatric dosing. That is like according to weight, we give the tablets. Okay, we need not memorize everything. So according to body weight, we prescribe the tablets of artemether and lumefantrine. The dose of artemether is 20 mg, lumefantrine is 120 mg per tablet. Depending upon the weight, we increase the dose. So by increasing the number of tablets in the particular child. How are we going to treat the complications? We already discussed anemia. Severe anemia, what will we do? We give packed RBC transfusions to maintain the hematocrit more than 20%. Sometimes, one more important thing in your diagnosis, see Plasmodium falciparum malaria, you cannot appreciate maximum parasitemia in your peripheral blood smear. Why? Because one of the important mechanism is sequestration. It is entering into your blood vessels and adhering into the blood vessels. So parasites outside or within the outside the vasculature is very less. So that is not the entity. So more and more on parasites you can see, or parasitemia are appreciating, that is the severe entity. In Plasmodium falciparum, even we cannot see any parasitemia, but the child subsequently fall into complications and the child may succumb or even die. And coming to this supportive therapy, supplemental oxygen and ventilatory support for pulmonary edema. We already discussed pulmonary edema is one of the complications because of increase in capillary and increase in capillary wedge pressure. Intravenous rehydration for severe malaria. Intravenous glucose for hypoglycemia. Because of hepatic dysfunction, gluconeogenesis will not occur, resulting in decrease in glucose levels, thereby landing up into hypoglycemias. Anticonvulsants for cerebral malaria with seizures. If at all the child is seizing, you have to give anticonvulsants at that point of time, because any seizure child you have to treat according to your seizure protocol. Dialysis, sometimes even dialysis can also require when the child presented with renal failure. So till we discuss the management part. The commonly used drugs for chloroquine sensitive area is chloroquine, and also the drug of choice for falciparum is artemisinin derivatives. We commonly use the drug artesunate at the dose of 2.4 mg per kg per day. Usually we prescribe 5 doses, but whenever the child intake is good, whenever we can give orally, we shift IV artesunate to the oral artemether plus lumefantrine. Usually we get the combination tablets of artemether of 20 mg, lumefantrine of 120 mg. The dosage depending upon the weight of the child, like 5 to 15 kgs, 15 to 25, 25 to 35, more than 35 kilos. So these are the things you have to remember. And for Plasmodium vivax, because of the hypnozoids, we need to give even sulfadoxine and pyrimethamine, the dose of 0.25 mg per kg per dose base drug for 14 days, and Plasmodium falciparum malaria 0.75 mg per kg per dose for single day. Those are the drugs we have to give add-on for Vivax and malaria. And usually we restrict ourselves like using quinine, hydrochloride and other drugs, because quinine causes prolongation of QT intervals, sometimes cardiac arrest, and sometimes refractory hypoglycemias. But all, if no other drug is available or any other potential problems in implicating the treatment of the routine, then we can go with the drug with quinine, but usually we don't prefer quinine. The drugs we use are chloroquine and artesunate. That's all. That is more than enough for you people to write in your exam. One more thing, chloroquine base. We give total dose of chloroquine is 25 mg in 3 days, like 10 mg, 10 mg and 5 mg, or 10 mg followed by 5 mg, 6 hourly and 12th and 24th hourly. This is another regimen, but we follow 10 mg followed by 10 mg followed by 5 mg. This is comparatively feasible, and I already told you whatever the dose we are discussing is base. Usually in a 250 mg tablet we get the base of 155 mg only, so one have to check your tablet, one have to prescribe. Next and last thing is chemoprophylaxis. Chloroquine and hydroxychloroquine 1 to 2 weeks before travel, weekly while in country, and for 4 weeks onwards. Whenever you are entering into our endemic areas, these are the chemoprophylaxis regimen one have to take. Doxycycline 1 to 2 days before, daily in country, and 4 weeks afterwards. Mefloquine 2 weeks before, weekly in country, and weekly for 4 weeks afterwards. This is daily doxy, weekly. Atovaquone proguanil 1 to 2 days before, daily while in country, and 7 days after. So prevention of malaria. Prevention is better than cure. The same old dictum, right? So prevent the mosquitoes from entering the house. Close door, windows, especially toilets. Well-constructed houses with window screens. Preventing the mosquitoes from hiding. Avoid dark corners, hanging clothes in rooms. Mosquito control. Protect against malaria. Protective clothing, protective nets, mosquito repellents, and insecticide-treated bed nets are most effective. Residual sprays. Malaria vaccine yet to come as expected, but didn't come yet. These are all under trials. Thank you. Any doubts? I don't think you read anything new from this topic. Just it is a revision of your basics. That's all. Because malaria, I think you are reading from your first year. Last year, I think you already gave an exam even. Any doubts? I'm not asking even a single question. Just why don't you answer, am I clear or audible, or any doubts? Just that's all. Or everyone gave your attendance? You can answer for this question at least. Shall I end the class?
Yes, ma'am.
Yeah. Any doubts you can ask in WhatsApp group or right here. All of you gave your attendance, right?
Yes, ma'am.
Shall I end the class? Okay, thank you, ma'am.
Thank you, ma'am.